think. And so now, welcome back, everybody. We spent the morning talking a lot about the work that UCSF and the Open Oximetry Project is doing, some of the results from the testing, some of the complexities around the challenge that we're seeing, and then hearing from some of the global bodies around procurement and how they select devices. And now we're going to shift a little bit to hear from Andolo and Janet and our Kenya team to talk about kind of what this looks like in practice in a country. And so I don't think there's any much more introduction needed than that. So I'll hand it to Andolo, whose name is on the screen, Stephen Maheso, who's our country lead for the TIMSI project in Kenya. Andolo, over to you.
Yeah, thank you, Mike. And thank you for the invitation to be part of these great discussions around open pulse oximetry. As Mike mentioned, I'll make this Kenya perspective presentation together with my colleague, Janet. And on the call there as well, Kenyan team members who, when we get to the process of questions and answer, they also participate. They may also participate in sharing their views. So may I start by saying that we had a consultation with the key stakeholders across policy, procurement, and regulatory, and we received different shades of opinion. May I start with what was clear and informing? Next slide. What was clear and informing, we were heard consistently through all these meetings, that we should not have a device that does not work well on all skin tones, and that the highest standards should apply across the board. This also supplemented by a comment that globally, if you are making a device and realize that it is not working for a certain population group, then there should be some regulation to say that it should be able to work in whichever marketplace. And I think that is a starting point, a clear indication from the head of Division of Newborn and Child Health in the Ministry of Health, who are the stewardship of the TIMSI project implementation. It should work on all skin tones, and whenever it doesn't, there should be a regulation to that effect. Next slide. In this slide, we just want to reflect that we had discussions and consultations with various key stakeholders. Among these one was the county stakeholders with TIMSI projects. We decided that we should interview or hear from projects or project sites where TIMSI project, a tools for integrated management of childhood illness, was implemented in Kenya. And we had a team of various team members who implement projects at the county level. We had also representatives from the Ministry of Health, which is the headquarters, who came from the Director of Health Products and Technologies, which is the director in the ministry that works, approves, and recommends products and technologies that are coming in the market and which should be adopted for use in the country. Then we had representative from Division of Newborn and Child Health, who are the key at the national level in the implementation of TIMSI project, and who also, if tools originate from child health, have the responsibility to engage stakeholders across board to be able to advance their use, their adoption in guidelines, and their uptake. Then we had also discussions with the Kenya Pharmacy and Poisons Board, and we had also discussions with other key stakeholders who are engaged in supply, procurement, and even distribution of devices. In this case, we had discussions with Mission for Essential Drugs and Supplies. Next slide. Yeah, so in this slide, we just want to reflect on what is the context in Kenya when devices are changing, what needs to be done, or what will be done. For us, start is to emphasize that KEBS, which is a Kenya Bureau of Standards, and PP, which is a Pharmacy Enforcement Board, are the two bodies who are mandated to ensure medical devices meet appropriate standards. So it is their responsibility to ensure that what comes into the country is actually cross-checked with the standards the country has adopted and authorizes their use. Key was also the Kenya looks to ISO and other countries that have pre-approvals to expedite the process and validation. What we had is that in Kenya, because the process of approval, the process of testing these items may be very expensive, may be repetitive, they look to these other countries who have agreement with them or who have the highest standards. And if they're approved in those countries, they can customize the standards requirements to the Kenyan context. The other thing we had done consistently so is that reliance is the key, relying on regional or global bodies. And they said if changes are required by ISO or Pharmacy Enforcement Board will comply because this saves resources. And I think what came out clear in terms of saving resources was one, even the capacity to also do some of the testing may not be available. So reliance on what is acknowledged and provides quality is acceptable. Then there was also an aspect where whether we could also have expertise within the country to be able also to do the testing. And then there also the aspect of how long it would take. So reliance was taken to be a key element in terms of context of how new devices are adopted in the country. Apart from that, now internally relating to the Pharmacy Enforcement Board, it actually authorizes guidelines. It actually it provides market authorization guidelines. And this could be revised if the pulse oximetry standards requirements are actually changed by ISO and other global agencies that it looks to. The other thing Pharmacy Enforcement mentioned is once those standard requirements are changed, it has the responsibility to communicate to manufacturers when standards change so that manufacturers actually comply. And this compliance to the manufacturer, for manufacturers to the new standards also depend on various circumstances, some of which will highlight as part of the highlights in the next slide. Next. Next. Yeah. So these are some of the highlights. And the Pharmacy Enforcement Board can actually phase out old devices. However, we are told this will depend on how below the standards that those are in the markets are. If they are well below the standards, they can actually be pulled from service to ensure accuracy in terms of whether they are being used as a diagnosis or whether they are being used as guiding diagnosis. And they also mentioned that there may be at times when they can be withdrawn as an emergency recall, particularly when they fall off the new standards that may come into being. And our health system being devolved, we're told, counties actually procure devices against standards and specifications that are actually cascade from the national level. So in the other words, we are told that there will be no problems in adopting the new requirement standards by the counties once they are adopted at the national level. And that adoption at the national level is also a consensus, and we'll talk about how it plays out as we move on. The other thing that came out as an highlight was that global agencies such as UNICEF, WHO, should be equipped with the information to facilitate counties to use certain specifications when procuring pulse oximeter. And earlier on in the discussions, we had a representative from WHO, from UNICEF, who went through what they do and what specifications they have. And I think I just want to say, in terms of the TIMC project, we had the opportunity to use UNICEF as a procuring agency for the pulse oximeters that we used in the TIMC project, which was in 3 counties in Kenya, and I think also in 4 countries that were involved in the TIMC project implementation. And I think out there, the feeling we got was that the products that were procured through UNICEF were of good quality standards, because as it was mentioned and was shown graphically by UNICEF, at the same time that was a COVID-19 period, and countries, including Kenya, were procuring these pulse oximeters from other agencies. The other thing is, if specification change, it will be important to share this information with the professional association, who also influence and practice, and will require advocacy with the champions in starting as a starting point to speak about the standardization of specification. And I think just to summarize this is, we heard that there is need to have a clear communication, and this clear communication start with the people who are credible, people who also will influence more, and others will fall into place. And in particular, to buy in, health professionals and would need also to be sensitized on the new requirements. And this sensitization, they emphasize, and I want to say, should be on studies that have been done that have evidence that qualify the need to switch from the current pulse oximeters to the new requirements, and giving how they perform in various study populations. And I think I'll reflect on that in the next slide. Yeah. So I think I want to hand over this to my colleague Janet to now talk about what were the concerns and what would be our summary. Janet, over to you.
Thank you very much, Andolo. Now, my name is Janet, and I'll be talking about the concerns that were raised during our engagement with stakeholders here in Kenya. The first concern was that due to the lack of standardized pulse oximeter requirements, cost now becomes a key consideration during procurement. And the counties procure the cheapest option. As mentioned by Andolo, in Kenya, we have a devolved system, therefore implementation of health is done at county level, and they are responsible for quite a bit of procurement. And therefore, when they are procuring, it's interesting to note that cost now becomes a key consideration. Again, though they have the standard procedures and structures for procurement, they do not really implement this. And when users give specifications, the user departments give specifications, these are not adhered to. And so this leads to procurement of pulse oximeters that do not perform well. Again, we find that because there's a lack of a policy framework for donations in medical devices, this leads to receiving these devices that are of varied specifications and also quality. And of course, this is a challenge because it's difficult to service and maintain different devices of which it's difficult to get the spare parts and things like that. Next slide. So now coming to the summary, pulse oximeter specifications will help us during the procurement process. And believe that a list of approved devices will be helpful, especially if new certification or recertification is to occur. And then testing of these devices on a wider population in different geographies will inform regulatory and procurement before releasing them for market use. This will be important, and this was discussed a lot this morning during the meeting. And then finally, we also found that communication on what countries should do with the current pulse oximeters will be key. And that brings us to the end of our presentation. Thank you very much.
Yeah, thank you, Janet. And maybe before we open it up for discussions or questions, I want to ask our Kenya colleagues on the call, I haven't checked to see who is present, to be able also to share some of their thoughts before we go into the discussions.
Thanks, Janet. I know, Andolo and Janet, thank you. I know Elsa was online earlier. I don't know if she still is. Maybe not. Anyone else from Kenya?
I know that Ambrose was.
Yeah.
Oh, Ambrose. Maybe not. Okay.
Yeah, Ambrose was, but they seem to have dropped off.
Yes.
Yeah.
Maybe we'll expand that out to any other regulatory agencies that might want to comment. John's in the room, or Brenda, I know, is on the call. If there's any thoughts or reflections. Or I know we have colleagues from Tanzania as well. Yeah, or just a general Q&A. Matthew Black.
Thank you. It's Matthew Black from Unit 8. Thank you, Andolo Asantenisana, for the team. So I really appreciated the rich inputs there, and it was a very good guide on how we can think about things coming into country and how we can think about in terms of scale up. I did just want to say that I think in terms of the messaging, we need to be very careful not to be giving a message that says pulse oximeters don't work for certain populations. So I think in terms of I agree with the sentiments of what was said by the director, that you need to make sure that regulations ensure that you have equitable access and everybody can use devices. But I just felt the way it was phrased makes it look like pulse oximeters are broken in general in some things. Yeah. So, yeah. But very much appreciated the inputs.
Yeah, thank you, Mike. I do agree with Plug. I do agree with you, and I think one of the things that was actually mentioned, we may not have captured in summary of the slide, was actually the expression that there should be wide use of also these pulse oximeters for people to learn how they are functioning, taking into account that when we introduce a TMC project, they are not available in the lower level facilities, level 2 and level 3. And even across board, the availability in countries, in Kenya particularly, was low. And I think, as was shown by UNICEF, since COVID 2022, their actually purchases also going down. So I think even in terms of uptake for Kenya, we were just beginning the process. We are just beginning the process of having them used on a wide spread. And then the other aspect, even educating people, training people, mentoring people on how they're working, were aspects that were also emphasized, particularly when we talk to the Kakamega County. Over.
Thank you.
Yeah, it's an interesting point on the communications piece on how we message this to, anyone really, but without a clear direction or path forward, I'm just curious if anyone has thoughts on the messaging, because pulse oximetry is a critical tool in identifying or measuring blood oxygen, which is a key indicator. And also for determining if someone needs oxygen and then giving that oxygen. But there is this question around the accuracy, or this challenge around the accuracy. So is there anybody who has thoughts or comments on the way that can be messaged at the higher levels, like we're doing now to this group? And then if or when or how it should be measured, it should be messaged within the facilities. And I think we would look to folks like WHO, Ministries of Health, to help us come up with that messaging. But
Bob has a suggestion.
Bob, yes, please.
Sorry, were you asking for me to jump? It sounded like you were asking for someone else just before I raised my hand.
No, I was asking for anyone and you raised your hand.
Right, so then the timing was impeccable. All right, fine. I think we are dealing with users that perhaps could be a bit more aware of the limitations of the technology. I believe, especially in children, at least this has been my clinical experience, that it is quite easy to see a child that is at risk for hypoxemia, either because of other symptomatology, that there's very labored breathing, a lot of coughing, there's a lot of exudate, there are a lot of indicators that lung function is challenged. Once you see a pulse oximeter value that doesn't agree with the clinical picture, I would highly recommend moving that to other sites on a child to help to verify that that number seems real. And also be aware of what are real visual indicators of hypoxemia, and that is circumoral cyanosis, blueness around the lips or inside the mouth. So I think, especially knowing, Michael Lipnick did a great job of saying they have tested more than 100 times in human desaturations of healthy adult subjects, these multiple different pulse oximeters. I think he mentioned there were nearly 30 of them that he's done that deep a dive on. But you were also made aware that there is nothing like that for any children that have been tested. And there are reasons, and Michael covered those too, about ethics, that you cannot do that in an at-risk population like children. So clinicians, users should be aware that these devices are not perfect. They need to be extra vigilant in their use in children, because data, meaning actual comparative data down to levels of hypoxemia, are really not available in that population. That was the point I wished to make, that better information to users in this group of care for devices in use in children less than 5 years of age, which is the focus of today's meeting.
Great. Yeah, thank you, Bob. Really helpful. And yeah, and I appreciate that focus on the children too. Malvina, I see you have your hand up as well.
Can you hear me now?
Yes, and see you.
Okay, great. So I think Pulse Ox collaborative community is really uniquely positioned in becoming the voice for communication to professional organizations around the world and patient organizations. I think you all are very clear on the messaging you want to deliver, discussing the best way to actually penetrate the appropriate groups who might not be aware of the discrepancies in pulse oximetry performance in different skin pigmentation is something that I believe your group is uniquely positioned in. So when I'm going to do my talk in a few minutes, you'll see that we have been extremely transparent in our communication and have issued quite a number of public communications. However, I'm also aware that the whole world doesn't go to FDA's website to check. And I think what we've done with other collaborative communities is the collaborative community decides on strategically on who is the audience that needs further education and what is the best way to communicate to them, and then issue some kind of a consensus, short, distinct consensus statements, and then strategically goes out to deliver that message. Thank you.
Okay, so summarizing, getting the collaborative community to come up with some short statements that can be provided. Is that something that is on the docket?
I think that's doable. Some of the subgroups around communications and education are working on some of that. It'll be interesting to see how much of that kind of fits the bill of what's been discussed. But I think there are some things in progress that maybe are heading in that direction.
Yeah, and then back to what Bob said, maybe there is some more, and I know I'm channeling Yasir in discussions that we've had previously when they're coming up with their guidelines for low-level facilities that may have limited training for their healthcare workers. There has to be very simple messaging. And so, but maybe there are messaging you can make, like, wait for a good reading or look at the trend versus a spot reading. As we continue to learn, maybe there are things we can create that can be used at all levels. Adina, please. I can't hear you for some reason. Adina, we can't hear you. I know you're not on mute, but we can't hear you. Oh, while we wait, Adina, there's a question. Well, Brenda asked a question about KEBS versus PPB in the chat. I thought maybe Jana and Dolo or one of the folks from Kenya could clarify that. It's actually a great question. And then there's a question from Gary around, or a comment maybe around countries' customs taxes and duties that add costs. We have seen that. We brought in our devices for the TIMC project. I think some of the countries we've got them waived, some of the countries we didn't. I don't have a solution for you though, Gary. I know that is actually kind of valuable income or revenue that countries do use. So on one hand, it's useful for them, but on the other hand, I know it does add a lot to the cost. Yeah. Adina, if you want to put your comment in the chat, maybe. Sorry, we can't hear you. Any other comments?
Yeah, maybe before another comment comes, we respond to Brenda's question.
Yeah.
The overall responsibility of Kenya Bureau of Standards is the umbrella government organization that ensures all products that get into Kenya market actually are of the country standards and that they conform to the standards that they speak to. So KEBS would actually then test some of these devices to ensure that they meet these specifications. But when it comes to the approval of use, and as a result also of oversighting to see that what is also in the market conforms to the requirements, that becomes the responsibility of Pharmacy and Poison Board, which is given the mandate of looking at pharmaceuticals as well as devices. So in terms of authorization, regulatory, supervisory, that would be the role of Pharmacy and Poison Board. And in terms of ascertaining that those items actually meet the standards, would be the role of Kenya Bureau of Standards. Janet, anything you want to voice over?
Just to say, yes, that is exactly what I wanted to say, but also to say that we work in collaboratively. So KEBS and Pharmacy and Poisons Board will work in collaboration. Thank you.
Great, thank you, Ndolo, Janet. John, does Uganda NDA, do they have a similar structure for a standards board and then a regulatory body?
Thank you, Mike. In Uganda, we have the National Drug Authority, which is strictly responsible for regulation of drugs, medical devices, and other healthcare products. We have Uganda National Bureau of Standards, which is tasked with regulation of other items outside the health industry. So there's a clear distinction on which items fall under which body. Yeah, so but we collaborate because we have members from India who are part of the UNBS, Uganda National Bureau of Standards Committee, and we collaborate on the kind of standards to adopt for particular items.
Great, thank you. See anything to add? Okay, so I think we have the next session, which, and what I've heard from Ndolo and Janet, and from UNICEF and ICRC, is that there's a reliance on ISO and FDA to kind of set those standards that they can then ask manufacturers to follow, which is handy because we have the next session, which has ISO and FDA to provide some information. And so maybe if there's no other questions, maybe we can just go into that session a little early. And that's going to be, I think, Bob and Sandy and Malvina.
Yeah, we're gonna start with USFDA.
We're gonna start with the US FDA. Dr. Malvina